It is now my pleasure to give the floor to Mrs. Mkondya Senkoro to discuss best practices of recruitment, training, and retention of health workers in Tanzania. The floor is yours.
Thank you so much getting this opportunity. The part and parcel of this UN expert group. And today I'll be representing the Benjamin Mkapa Foundation, which is a local entity established in Tanzania. I'm the CEO of the foundation as a founding CEO. My name is Dr. Ellen Mkondya Senkoro. I got to get the right word to pronounce the African names, but I like to be called Ellen. That's easier. And I've been working with this foundation for the last 18 years since its inception. So my presentation is really going to be presenting and sharing the experiences which we've had in terms of tackling the human resource for health crisis in Tanzania, which is one of the common situation in most of the sub-Saharan African countries. And before I share the best practices, I just wanted us to get the understanding of our situation in Tanzania. We're populated with around 61 million people. Actually, Tanzania is the largest African country in East Africa. Sorry, in East Africa, we're the largest. And we're surrounded by 8 other countries bordering us. And we have an annual growth rate of about 3.4%. Our population is around mostly young population, with 44% being young people under 15 years of age, and 35% between the age of 15 to 35 years old. Our life expectancy has been increasing gradually at around 66.7%. We also appreciate the great achievements we've made in some of the health indicators, especially on maternal mortality, where we have reduced it by 60% from where we came in 2016 to now. We were reporting about 556 maternal deaths per 100,000, and now we've been reporting at 250 maternal deaths per 100,000 live births. In terms of child mortality, we are progressing very well towards achieving the SDG goals, except with the newborn deaths. We're still not doing very well. Newborn deaths are still high at 24 deaths per 1,000 live births. And I think that's an area where we need to put a lot of efforts. In terms of fertility rate, it's quite high, because it has gradually reduced very slowly at 5.4, where we were before, and now we're around 4.8 children per woman in the past 14 years. But we are also observing a quite steep rise in non-communicable diseases, including road traffic accidents, having around 44% of the deaths being caused by road traffic accidents. Yet we're still suffering with the communicable diseases, though with some encouraging outcomes in terms of the HIV/AIDS indicators, especially the 95, where we're faring very well. In terms of health insurance coverage, we haven't done very well. We're still struggling with that, grappling with that. However, we are happy to see that we've just had our universal health insurance legislation bill, which was passed by the parliament. And now we're in the process of developing guidelines of operationalizing that universal health insurance. Going straight to the subject matter of the human resource for health, annually, at least average, we have around 10,000 to 24,000 health workers being produced from the training institutions per year, but only less than 50% are being absorbed in the employment. And it goes to the second slide, to the following slide. Okay, there's another slide. I think I just missed it out, but there was another slide which was really showing that in terms of production, we are producing around 96,000 health workers. In the last 10 years, we've produced like 96,000 health workers. But in terms of recruiting, we've recruited only 52%. So 52%, the other 50 is remaining unabsorbed into the normal recruiting system. So here we come as our institution, Mkapa Foundation. This is the foundation which was founded by His Excellency, former President of Tanzania, 18 years ago, and working very closely to complement the government efforts to achieve the SDGs, the UHC indicators, but also the national priorities. And so far in 18 years, we've implemented more than 35 projects. We've covered more than 90% of the Tanzania as a country and impacted more than 26 million people with different initiatives which we've been carrying out. More importantly is the health workforce initiatives, where we've given out more than 1,000 health scholarships, but also created jobs innovatively within the health sector so that they can fill in the gap, which is within the country. Yes, I'm very active in terms of having initiatives on service delivery, and we were also very proactive in terms of coming in when we had the first emergency outbreak of COVID in year 2020, where we were one of the institutions that were very much in the forefront to coordinate all other CSOs' efforts within the country to address the emergency response, but also in accelerating the vaccine uptake of COVID-19. And despite having interventions on the ground, we are also very actively engaged at the central level, policy and advocacy. And I think that's one of our great strategies, where we combine the dual approach of on the ground and the policy engagement. Now, coming to the HRIH, what were really our lessons learned in terms of the human resource for health? We decided to design our own model, which was very much received by many partners, but also by the government, quite embraced by the government. And because from the word go, we try and align our parameters on human resource for health in terms of the recruitment process, in terms of the skill and job matching. So we align the type of salaries that these health workers are being deployed with. They match the government salaries, but also the pay structure and the systems. You utilize the existing government systems which are existing within the country. So our planning process has been quite engaging. We really identify what are the needs. We prioritize together with the government and allocate them and deploy them using the same government systems. So we use more of scientific methods to really deploy these health workers by using also the workload indicator staffing needs. What is really in the needy, what are really required in specific facility, and such that they'll bring an impact. But we are also aligning ourselves with the government protocols and their payment systems, as I said, and also utilize the professional council regulatory authorities to scrutinize and see that these are health workers that are in alignment to professional, they're qualified, and they can go and work despite being trained. Most of them are being trained from the country level. And we facilitate also the entire aspect of appraisals and performance management using the same government system. By doing so, we've been also training and building the capacity of the human resource management team in those districts. I mean, starting from the national levels, the zonal level, and to the district level. But also before they're being deployed, we give them orientation. And it's through these orientations, that's how they understand the public services, how they work, the do's and the don'ts and the systems. And this also led to us to develop an orientation package, which was adopted by the government, and now it's being scaled out countrywide. To complement these efforts, also we have the Community Health Workers Program, where we were piloting the different initiatives of community health workers and how it complements the efforts of the facility-based services which are being provided by skilled health workers. Next slide is just showing our coverage for the last 18 years. As you can see, this is the map of Tanzania, and we've covered every part of the country, including Zanzibar. That's the island. As you know, we are a union government. And through this way, we've been able to deploy about 7,000 plus skilled health workers, but also community health workers, around 6,000 of them. This is the data until 2023, I would say, but until now, we've added a little bit more. So with the recent deployment, we'll be able to proudly say that we've been able to create jobs about 16,000 health workers. And on annual average, you would say we manage around 2,000 to 2,000 health workers. And these are mostly the clinicians. We have data managers. It's about a sketch of about, it's about 15 cadres, 15 plus health cadres, nurses, pharmaceutical personnel, the labs, expert clients, but also radiographers and many other health professionals. But our model has always been, how do we sustain this kind of initiative? It's not only deploying and when the project ends, the person leaves, but rather how do we transition them now to the government employment system? And so for the last 18 years, as you can see, the trend has been rising. We started with just 87 being transitioned to the government, but now we have almost 1,600. In total, cumulatively, it's almost 50% of whatever we've deployed have been streamlined in the government. And this is possible because we have a special memorandum of understanding with the government, but also from inception, from the orientation, from identifying them, we do it jointly with the government. And so they feel these are more health workers that can be retained in the health systems, especially in the underserved areas. And we pick really underserved and areas that are marginalized or have some crisis in with health workforce. Lessons learned in terms of training. So our training approach is really looking at 3 pillars, I'd say. One is to see how we enhance e-learning, whereby we realize there's a College of Distance Learning in Tanzania, which did not have online learning courses. And we managed to support it in terms of developing curriculum, in terms of equipping that center. And now we see about 34,000 health workers have been utilizing that e-learning system at the government. But also even now we're moving towards having this online training to be used for CPD, continuous professional development for the health workers. Another approach we've been using is to see now how do we build, as I said earlier, the human resource management capacity of the districts and the regions, but also doing an on-job coaching and mentorship skills. You would say this is a bit demanding, but how we do it through the zonal system. From the zonal training institution, we build the capacity, and they're the ones doing it downstream to the districts. And the third area is on training scholarships, and these training scholarships are mostly divided into 2 areas: pre-service training scholarships and in-service training scholarships. And we identify these scholarships based on the needs, again, as I said earlier. For instance, we've given almost 930 scholarships to rural students that graduate from secondary school, and they were being trained on allied health courses because the PHC level shortage is quite critical. Actually, it's almost like 70%. Overall, national average is 66%, but the primary healthcare level is quite critical. And this was mainly because also we were giving them on diploma and certificate for nurse anesthesia, for pharmaceutical and labs. And this was based because there was a huge investment in terms of building theaters at the primary healthcare level so that they can give comprehensive emergency obstetric care. With time, we are also coming in service scholarship, and this also is notable because there's a lot of investment which has been going on with training the nurses with many other partners, but we realize that some of them miss the midwifery skills, and we've introduced at the country level the advanced diploma in midwifery, but many of them cannot afford to go and pay for such courses. So we are doing more of in-service training for those health workers that are already working in the rural settings. In terms of retention, we designed in the past, almost like 10 years ago, we started seeing that even if you send these health workers in the rural settings, you give them allowance for their housing, there's no place to stay. Most of the houses are very poor condition, but also the working environment is very poor. So through the support that we received from the Global Fund, we managed to build almost 482 houses countrywide. And this was the model which was adopted again later on by the government. And now they're doing massive investment on infrastructure comprehensively, not only looking at a hospital facility, but rather compounding it together with a staff house. Any infrastructure development in a hospital has to go with the staff houses construction in those areas. In terms of policy and advocacy, as I mentioned earlier, we believe all these things you need to be at the center of discussion at the ministerial level, with the policymakers at the parliamentary level, with the MPs, to be able to influence some national frameworks. So we've been co-developing and reviewing a number of national frameworks of Tanzania. For instance, we introduced the National Health Staff Scheme of Service. We provide the technical assistance, of course, using our own consultancy, mostly a local consultants and ourselves, but also developing a volunteerism guideline, which would help those health workers that are in the labor market to be deployed and work in volunteerism basis by being given small incentives in the facilities. And also, we, as I mentioned earlier, on the National Community-Based Health Workers Program, we were quite active to institute and reinstate this kind of program, which we had many years ago, and now it has been reinstated. Live Alone, we've also been engaging other multi-sector. We don't only work with the Ministry of Health, we work with around 5 ministries, which we believe have influence on human resource for health planning and budgeting. And this includes the Prime Minister's Office, which is mandated to lead multi-sector responses. And they're the ones who are in the forefront: Ministry of Finance, Ministry of Education, Ministry of Health, and the President's Office, local government and regional authorities. And we are very actively engaged in the technical working group. Tanzania is quite advanced in health sector-wide approach program, and they have different 8 technical working groups. So we are there on the table. We are also given the opportunity to co-chair most of the human resource for health technical working group. And recently with the community health road task force, which is aligning itself and coordinating the community health roadmap, we are the co-chair. Quickly, I just want to start to move further. We also have been developing national personnel deployment plan, especially during public health emergency. This is work ongoing at the moment. And we've also finished just the human resource for health mapping exercise in Zanzibar, particularly to see the number of health workers that are existing based versus what is really required, and how many should really continue working out, or how many should be built their capacity, how many are existing, how many are not there. So this is an exercise which is still going on in Zanzibar. But more so, given our experience of being in the policy and advocacy table, we were able to influence our other CSOs, fellow CSOs, the local and the international NGOs, to be part and parcel of these policy and advocacy forums, so that our voices are more stronger and well heard. So we were chairing this the non-state actors health group for the last 9 years. Through that multi-sectoral policy forum, which is led by the Prime Minister's Office, we came up with options. We said we can't continue depending on the government normal way or conservative way of recruiting health workers. So one was to come up with in-country solutions, which was, can we have volunteerism, which is well structured and well remunerated, and this has been adopted. And we see this taking up on by big hospitals, especially the regional referral hospitals, a bit challenging with the primary healthcare. So now we are also undertaking an assessment to see how impactful has this volunteerism program been so far. And we believe this can be remunerated through different alternative financing. But we also came up with another option, which is yet to be operational, is how can we operationalize private clinics or polyclinics, supporting these medical doctors that are in the labor market to start their own polyclinics, and so that they can improve in terms of employment, but also economic boosts. And another third area was because there are huge investments of government onto these hospitals, whereby some of the hospitals are underutilized because of shortage of health workers. We are thinking we need to come up with arrangements of these doctors being attached to those hospitals and getting into public-private agreement or arrangements to provide services in those hospitals. This is also something in the making at the moment. And the last two areas is, of course, improving and supporting the scale up of medical related startups. There are quite a number of those. And of course, they have their own limitations in terms of financing, in terms of rolling them out, marketing, and making them sustainable. So, and these are coming up, being designed by many young doctors and young health professionals or nurses, etc. And the third area is, of course, upscaling the community health workers program. Internationally, we've started exchange programs. It's quite intense now. It's coming all the way down to the district hospital, regional hospitals, and the super specialized hospitals. And of course, international recruitment of health cadres is opening up while we are really trying to see how we align ourselves to the WHO Global Code of Practice with some limitations. But I think this is an area where we are embarking into as Tanzania, and Kappa Foundation is part and parcel of this initiative, working closely with the government. But also we see best way of optimizing cooperation agreements between Tanzania and other countries. Community health workers, just say a little bit, just this slide, which is showing the process, which we've been engaged, quite actively engaged in terms of orienting selection of these community health workers by the villages themselves, doing advertisement, orienting the district and village level selection committee. We do the screening. All is government led. We are just providing the technical assistance. And because we learned the last 7 years, we've been doing this. And we saw this is something that is feasible and sustainable. And the main essence is to see that all efforts which are going on by different CSOs, NGOs, some are doing TB, some are doing HIV, some are doing HIV, very parallel. How do we coordinate them? Or how do we enhance the integration and sustainability of these community health workers program? And so far we're doing quite well, because Tanzania is aiming to engage or hire around 150,000 community health workers in the next 3 years. And for this financial year, we've already started engaging around 8,000. The plan is to engage 8,000. Kappa Foundation is already vested with the responsibility of more than 2,000 of those. And it's a learning curve. There's an operational research also integrated into it. They're sent to 6 months training, which is blended between field and classroom, 3 months in classroom, 3 months in the field, and then they're later on being deployed to work in the community health. But more so, which is quite exciting time for us, is seeing community health workers training curriculum is also capturing the curative services, which was never the case in the past. And so this is something that we'll really need to be following through and see the results in the long run. Final but not least, just last 2 slides I'm finishing. The NGO landscape in Tanzania, we're about 6,000 of us, different sectors, including health sectors. Of course, majority are in the health, but NGOs are very much involved in the health swap process and forums, policy dialogue, but we're also engaged in country proposal write-ups, but also responding to outbreaks, etc. And under the Kappa Foundation leadership, as I said earlier, we were able to improve our coordination among ourselves. And now we've handed it over to another chair, another organization. Yet, good practices, but there are challenges, and we see some opportunities. And some of the challenges that we've seen, of course, is the financing dynamic. We all agree, we all see the shrinking of the financing, whereby most of the NGOs are reliant on donor financing. But also we are seeing the donors shift is going more into government relations or financing, and limited we'll be having limited CSO funding windows, which I think is something that we really need to look at, and how we reposition ourselves as CSOs through this change in dynamics. Yet we realize the number of international organizations who are localizing themselves, and so the competition is also becoming steep. But that tells us we need, as local organizations, to build our capacity also on organizational development and sustainability strategies as NGOs. And most of the NGOs are very much projectized, maybe one project or two projects or one donor with a massive support. So sustainability is an issue, and they're mostly service delivery inclined. Very few are doing system strengthening or HRH strengthening aspects. So I think this is also an opportunity how we can continue building their capacity. The opportunities I see, we have very strong best practices at the country, however, poorly documented. And I think this is an area where we really need to have more support, including we have HRH forums where we bring different stakeholders to discuss and deep dive on solutions of human resource for health. So this is a great opportunity, which Kappa Foundation is leading this forum in collaboration with the Ministry of Health. But also we need to optimize our trusted partnerships between the government and NSAs. I think this is quite strong. And of course, leveraging on the UHC initiative, especially the Universal Health Initiative, which is coming in Tanzania. And already there are high supply of human resource already in the labor market. Few policy recommendations. I'll not go one by one because I've heard most of my other colleagues have touched on them. It's not secret that we need to invest on non-communicable diseases because we see the steep rise of this situation, crisis, especially mental health, hypertension, diabetes, and injuries as well. So that means we need to invest more on public health. I don't see this coming very strongly yet in some of the countries, including ours. Still, we want to invest on clinical care, which we think is something visible and maybe easily to measure. We, of course, see the rural-urban migration and poverty levels such that this also hinders a number of people accessing health financing. They have to pay out of pocket. So we are quite positive that with this universal health insurance coming in, perhaps this will be an answer in some of these challenges that we're facing. However, yet still we need to see more support technically at the country level to make sure that we have a universal health insurance that is feasible and not able to leave anyone behind. The youthful population, again, and we all understand how to invest more in adolescent sexual reproductive health beyond the conventional way. They don't come to health facilities, but rather how do we give them safe space and reach out to them to be able to address their challenges. Emerging outbreaks is an issue that we all understand is coming up, so global health security should be considered and a One Health approach. And chronic conditions coming up, aging population, more attention should go on maybe geriatric care, and of course, leverage technology and digitalization. Final but not least, in terms of HRH investment, in alignment to what I just said, it means we need to invigorate our way we train our health workers to align to these changing dynamics, which you're already seeing, and coming up with different variety of employment models among the health workers, and advocating for more domestic financing on human resource for health initiatives as we move along. And my plea is really to see how these UN agencies, WHO, World Bank, others, how can they really support some of the studies and research and more analysis on why should we invest on human resource for health in the long run for better outcomes of health and its people. And final is on the CSOs. We are critical stakeholders, which we feel we should continue innovating and being on the table of the policy and advocacy dialogue, not forgetting enhancing our private sector engagement. Thank you for your attention, everyone. Thank you.